Again, I want to thank John Furtek and the organizing committee for inviting me again to participate. It's really a pleasure every year to come down to this meeting. It's incredibly educational, and I really do enjoy it. And again, I want to thank them for the opportunity. This morning, we're going to talk about one of the things that we don't like to talk about, and that's the legal aspect of practicing medicine. Unfortunately, the legal aspects involves not only vascular surgeons or radiologists or cardiologists, but it also involves technologists, it involves nurses, it involves all ancillary people in both the operating rooms and the cath lab. So what we're going to do is we'll start out talking about that. Then Dr. Jeb Hallett will speak to us about the Stark Laws. The Stark Laws are a group of laws which govern how physicians actually interact with hospitals and in truth with each other. Now, the important things about Stark Laws, and I'm sure Dr. Hallett will go into it, is that you have a bunch of people in the government, a bunch of lawyers working for the government, and they're all in their little cubicles every day. Now, the only way that they can get out of their cubicle and get into an office with a view, with a nice window, is to take somebody down. They've got to take down a big hospital system. So if they take down a big hospital system, they get over there. So I can tell you they're looking out there to try to get that big score for themselves. So again, you're on one side, they're on the other side. And then finally, Ms. Marquita Ebersol will be talking to us about fraudulent billing. This is another important topic, obviously, and it involves, again, hospitals, it involves physicians, it can involve ancillary personnel. So these are all very, very important things that you need to know if you're going to practice in the medical field in this country. Let me get started first and just sort of give us an overview of medical malpractice. Now, I entitled my talk here. Let's see if I got it there. I entitled my talk Medical Malpractice and Liability for All. Now, okay, what I thought I would sort of be cute, again, as old as I am, I looked at this and I said, well, there's an old Al Pacino movie, and Justice for All. So I thought, well, okay, I would title this and Liberty and Liability for All. Now, interestingly, one of my kids said to me, Dad, I don't understand. What does your legal talk have to do with Metallica? And I found out that the album that Metallica did, one of their biggest albums, was And Justice for All. So for those of you who are younger, this talk has nothing to do with Metallica. Okay, so if you were wondering how Metallica fit into this, it doesn't. I have no financial disclosures. Now, as far as medical malpractice and litigation, the response of most people in the medical profession, no matter how you participate as a nurse, as a technologist, as a doctor, to being sued is probably this. Okay, you get the lawsuit and this is what happens. And you think about it for a second, and you think about the patient that sued you, and you think about the lawyer that filed the suit. And this is your next response. Okay, you just decide who you want to go after, which one, in which order. It's just whether it's going to be the patient or the lawyer or both at the same time. But the truth is, what you should be thinking about is how can I best understand the legal system so I can help my attorney provide the best possible defense for me. Okay, now, again, potential liability. Potential liability is for everybody. You have physicians who have liability. You have nurses who have liability. The radiology technologists, they have liability. The hospital clearly has liability, and industry can also have liability in these kinds of situations because, again, when it comes to the legal system, the lawyers look at this and they say the more the merrier. Everybody who they can get into a suit probably has some kind of insurance. Each policy adds to their collection. So basically what they're trying to do is get anybody and everybody they can into the lawsuit. Now, who are the prime targets? Well, you'd think that the prime target's going to be the physician, the physician in the case. That, in fact, is not the case. The prime targets are residents and technologists and nurses. And why are these people the prime target? Because if you get them, you get the hospital. As Ms. Eversole will know, if you got the hospital, you got the deep pocket. Okay? They got all the money. And that's the first thing they teach you in law school. Don't sue anybody who doesn't have any money. It's not worth the time and effort. You only sue people who have money. A couple of terms I want to talk about very quickly again, because we talked about the hospital and talked about nurses and technologists. There is the term that we use in the law called vicarious liability, or what we call respondent superior. What that means is let the superior respond. The employer, the hospital in this case, receives a benefit from the actions of the employee, of what the things that they do. And therefore, the employer is responsible for the actions of that employee. Another term that we need to understand is also what we call apparent and applied authority. Now, one who exercises control over the actions of another. So if you're a technologist or you're a nurse and you sort of look like you're to the patient that you're controlling the situation, you have shown implied or apparent authority. And again, the employer can be liable under those cases. Okay, so let's go over the basic components of a medical malpractice. If a lawyer wants to sue you for medical malpractice, they got to show four things. They got to show there's a physician-patient relationship if it's a physician. They got to show, or if you're a technologist or a nurse, you got to show that there was a duty. Second thing they got to show is that you breached that duty, that you didn't do what you were supposed to do. Third thing is got to show proximate cause, meaning what you did actually caused the damages. And then finally, they've got to show damages. Okay, now let's talk quickly about the physician-patient relationship, which is basically the duty part. Okay, how do you get a physician-patient relationship? Well, you can have a direct phone call. You can have direct patient contact. I go in and I see a patient, I've got a physician-patient relationship. Everybody understands that. That's very straightforward. I can get a phone call from the emergency room. Emergency room calls me up and says, Dr. Brown, we got this guy in the emergency room. He's got a bad foot. I think he's okay. You can see him in the morning. And I say, okay, great. I go back to sleep. I come in the morning. The foot's dead. And I get sued. And I say, well, wait a minute. You can't sue me. I never saw the guy. That's untrue. I have a relationship with him. Once I take that call, I've got a relationship with that guy. Social setting. You can get it, and I'll give another example. You give out advice in a social setting, whether you're a physician or any type of person, a professional. You give out advice, you potentially could have a relationship, particularly with physicians. Sidewalk consults. Sidewalk consult, it's not uncommon. A physician will be walking down the hallway. Someone will say to me, Dr. Brown, I got this guy who's got this, this, and this. What do you think? And I'll go, well, if I saw that, I probably would do A, B, and C. And they go, oh, okay, thanks a lot. They go back to the chart, and they write down or type in, case thoroughly discussed with Dr. Brown, who is the chief of vascular surgery, and we're going to do this, this, and this, because that's what he said to do. So, suppose what I said doesn't work out too well, the patient gets sued, patient sues, he ends up suing me. And I look at this and go, wait, how did I get sued? Do I have liability there? Well, actually, I don't have liability there, because I don't have a physician-patient relationship. That was just advice I gave on a sidewalk consult. On the other hand, if they call me and they say, listen, could you just put your hand on this guy's belly and see what you think and let me know? And I walk in and I go, nah, I think it's okay. I think it's benign. Now I do own it. Now I do have a physician-patient relationship because now I got my fingerprints on it. Okay? The last thing is payment. People say, well, I didn't pay. I didn't charge the guy. I saw this patient. I did this. I didn't charge him a thing. How can he sue me? Payment is unimportant. Absolutely unimportant. So what's the important thing to remember? Charge everybody. You're getting sued anyway. Okay? That's a whole different issue. Good Samaritan is a whole different situation. Okay? Falls under a totally different category. This is basically if you don't charge somebody, you still are liable, whether you charge them or not. This is an example of a case that was actually I reviewed. Person was a guest at a party. I asked the vascular surgeon. They said they'd had a 3-month history of leg swelling. They said, do you think it's anything important? The vascular surgeon, who probably had 4 or 5 drinks, as any of the vascular surgeons that I know, said, nah, it's probably a swelling. It's no big deal. Don't worry about it. It's probably nothing significant. You've had it for 3 months, but you ought to go see your doctor. The woman said, he told me it's okay. I'm not going to go spend the money, the time to go see my doctor. He told me it was okay. I'm not going to do that. She suffered a PE a week later and died. And so the question came up: Did that physician have a physician-patient relationship with that person? Well, most physicians would say, no, I didn't see him in my office. I didn't talk to him, whatever. But the plaintiff lawyer would argue that patient detrimentally relied on you. You said it was okay. So be very careful about advice that you give in any type of social setting. Remember, the law is really what the judge and the jury say it is, not what you think it is. Okay, so once you got this relationship, how do you get rid of it? Well, obviously you can get fired. Some of you younger physicians who think you will never get fired because you always take good care of patients and you are just a terrific physician, I don't know how to break this to you. You're going to get fired. It's just the way it goes. You can't please everybody. So that's one way, at least, to get rid of that relationship. 2, you can withdraw from the care after giving sufficient notice to the patient. So you can have a patient, they can be done. You do, say, a vascular surgeon, do a carotid endarterectomy on them. A month later, 2 months, you follow them, you say, you know what? We're done. You need to find another vascular surgeon. I don't want to really want to deal with you anymore. Now, you got to give them notice. If that guy shows up in the emergency room with a ruptured aneurysm, you can't say, this guy was a pain in the butt before. I took care of him. I'm not taking care of him now. Call somebody else. That would be abandonment. You can't do that. But if you give him enough time, you can. And obviously, if the problem that you treat him for totally resolves and he comes back to you 10 years later, you probably don't have a relationship then either. You'll always hear about standard of care. Everybody's always talking about, well, what's the standard of care? What's the definition? The standard of care is what an ordinary individual or ordinary physician would do under like or similar circumstances. It's not what the average physician, because by definition, if it's what the average physician would do, 50% of the people are committing malpractice every day, okay? And it's not the best medical care. It's what the ordinary physician would do. All right, now how do you establish the standard of care? Well, you can have an expert witness. An expert comes in and says, this person violated the standard of care. Okay, you establish the standard of care. Next, the defendant can say, yeah, I violated the standard of care. As you can imagine, that's the least common way that it's established. Res ipsa loquitur, it speaks for itself. You leave a sponge in the abdomen or a catheter in somebody after you do an intervention, you don't need an expert to say that that's negligent. Okay? Everybody knows that. It speaks for itself. If the plaintiff is a medical expert, they can tell you that they did it, that it's a violation of standard of care. And finally, common knowledge. If you're in there, you're the technologist, you're the physician, you're the nurse in a radiologic procedure, and the woman is 6 weeks pregnant, 8 weeks pregnant. You say, I just want to get a few extra films, and somebody says, should we get a shield? No, I'm just going to get 5 or 6 extra films without the shield. Okay, everybody walking on the street knows you shouldn't do things like that. So that you can also establish the standard of care that way. I just thought I'd show a picture. Obviously, you don't need an expert. This is res ipsa loquitur. You can see the scissors sitting in the chest at the end of the case. You don't need an expert to say that this is malpractice. The standard of care, you should know, is a national standard. Okay, the standard of care in South Carolina is the same as it is in Michigan, is the same as it is in California. Okay, there is a locality rule. Locality rule means if you've got a 200-bed hospital, say, or a 150-bed hospital in Savannah, and they say, well, you should have had this type of x-ray machine here, a 350-slice scanner. You don't have to have a 350-slice scanner. So there is a locality rule, meaning you are given some leeway with what you can have in your hospital. But the standard is national. And the standard for a resident and a fellow is different than it is for an attending physician. All right, now proximate cause. Remember I said you have to have, this is the third component. What you did actually has to cause the problem, okay? This is another case that I had reviewed. Patient died on the first postoperative day following an elective open AAA resection. At autopsy, they found a sponge. Now, there was no recovery for that retained sponge because it didn't cause the patient's death. There was no proximate cause. All right, next Informed consent. We always talk about informed consent. Informed consent. This is what I see on charts. Risks and benefits discussed. This does not constitute informed consent. Okay? This is not what needs to be on the chart. Informed consent has 5 components to it. And a good plaintiff's attorney is going to look for all 5 of these things. They're going to look for the diagnosis. They're going to look for a treatment plan. They're going to look for risks and benefits. They're going to look for treatment alternatives. And they're going to look for the prognosis with and without treatment. If you don't have all 5 of those components in there, you potentially did not obtain informed consent. You basically have to tell the patient anything that could affect the patient's decision whether or not to proceed with treatment. Now, there is a difference, and a critical difference, between informed consent and a consent form. The consent form that you all have people sign protects you against criminal and civil battery, okay, which is an unwanted touching. Now, if you tell the patient you're going to do the operation and then you do the operation, then it's assault and battery. If you don't tell them you're going to do anything and then just do it, then it's just battery. But if you tell them first, then it's assault and battery, okay? And the point is that your malpractice insurance does not cover battery. It covers malpractice. So if you're found guilty of civil battery, whatever that amount they come up with, you pay out of your pocket. So you got to make sure you have informed consent and a consent form. It's also a non-delegable duty. Don't send in, if you're attending, don't send the resident. Don't have a nurse. Don't have a technologist. And as a nurse or a technologist, I would sort of decline getting informed consent because it puts you in a very uncomfortable position. As far as, again, informed consent about what do you have to tell people about your experience, this is Johnson Kokomore. Dr. Kokomore had just finished in neurosurgery. He had done a bunch of anterior cerebral aneurysms but never done a posterior one. Patient came in with a posterior one, and patient said, do you do these? He says, I've done a bunch of aneurysms. Don't worry about it. I can take care of this. So what happened was they did the posterior aneurysm. The patient did very poorly, and they sued him. And the judge said he had been what we call puffing, or saying, well, he did way more than he did. He did not give a true evaluation of experience, and he was found guilty of not giving informed consent. Now, residents in particular get crazed about this. And they say, wait a minute, you mean I have to tell them so that if a patient comes in my first day in practice and they're going to have a carotid, I have to tell them, this is my experience. I've never done this operation before. You're my first patient. I can't wait to get started. When do you want to do this? You don't have to tell them that, okay? Because you are able to count the cases that you did in training. But again, you don't want to overstate the cases. As far as medical records, you got to set up the paper trail. If you don't write it down, it didn't happen. And take time to write down your thought process, okay? Patient comes to the emergency room, they got some back pain. After you examine them, you say, well, I don't think this is a ruptured aneurysm. It's only 4 centimeters. I'm going to watch them. I'm bringing them to the hospital because I'm not 100%, but I just want to keep an eye on them. 2 notes you can write. First note, patient has known abdominal aneurysm and back pain. Will admit and observe. Second note you can write. Patient has a known abdominal aortic aneurysm and back pain. Although back pain can suggest possible expansion or rupture, I do not believe patient's aneurysm is symptomatic. However, will admit and observe. Situation discussed with patient and family. All state they understand and wish to proceed in that manner. Now, when that patient ruptures at 2 in the morning, which note do you want on the chart? No doubt about it. Okay. Same thing with nurses and technologists. You have a patient comes in, they're going to have a catheterization. Patient's got an elevated creatinine. You need to document that you told the physician that the physician was made aware that the creatinine was elevated. Right? Now, you need to tell it. You don't need to editorialize. So in other words, you have no obligation to say, I told this guy the creatinine was elevated. I can't believe he's going to do the procedure, and sign the note. Okay? That's not a good thing to do. All right? You never want to fight on a chart. You never want to put things like that on the chart. But on the other hand, you do need to protect yourself. And if you're the one responsible, then you need to write down, patient's creatinine is 2.6, Dr. X informed. And then that's it. As far as office practice, you got to document phone conversations with other physicians. It's really interesting. Once a lawsuit is filed, your colleagues tend to develop amnesia. There was a classic case where a patient underwent a FEMPOP bypass. Patient had been seen by a cardiologist and cleared. The vascular surgeon called the cardiologist, said, I got to do this guy's fem pop. Is everything okay? He said, yeah, don't worry about it. He's cleared. But he never wrote a note. He just told the guy over the phone. Guy went ahead, did the fem pop. Patient had an MI. They sued the physician. They took the cardiologist's deposition. He said, did you clear this guy? He says, I might have. I don't really remember. I don't know if I did. I don't see a note in the chart. So I may have, but I'm not sure that I cleared it. And obviously the vascular surgeon is hanging out there in the breeze. When you write medical notes, make them legible. And if they're going to be written, obviously you want to be very clear and concise. And I'm sure Ms. Hebersol will speak to this specifically, seeing a bunch of notes in the hospital. You want to make sure that you write down exactly what you want to write down and what you want to say. These are notes from a chart, some actual notes in the chart. Patient was shot in the head with a 32 caliber rifle. What's their chief complaint? Headache. Okay. Patient referred to the hospital by a private physician with green stools. Okay. You got to take care of the physician. Patient's been married twice, but denies any other serious illnesses. That's more or less funny to various people. Various people have different response to that. My favorite. Mycostatin vaginal suppositories number 24. Insert until exhausted. Okay? Be careful what you write on charts. All right. Again, Good Samaritan Acts, speaking specifically to your question, your issue of Good Samaritan Acts. In most states, there are Good Samaritan Acts which protects you for going in as a Good Samaritan, whether it's in the hospital or outside of the hospital. It can be roadside. It can be in the hospital. Some states have specific issues that if you do accept payment for a Good Samaritan Act, you do have potential liabilities. Some states say that. Some states say if you are a Good Samaritan, you have no liability. So that in Michigan specifically, if I get called into room 3 and somebody's got tremendous bleeding and I go in there and save them, I am immune from being sued for malpractice, for simple negligence. I am potentially liable for what they call willful and wanton acts. So in other words, if I save this person's life and I say, I want this person to remember I saved their life, and I carve my initials in the bottom of their abdomen, that's willful wanton. I can't do that, okay? I'm going to be held liable for that. Okay? This is not, despite what some people tell you, medical malpractice litigation is not a team sport. It's everybody for themselves. And unfortunately, this doesn't progress well. But basically what the cartoon said, could everybody check and make sure they have a lawyer? I seem to have ended up with 2. All right? And that's what these tables look like. We're a bunch of people. You have your lawyer. That's your team. This is not a team. That's your group. This is not a team sport. Yes, you defend things with the hospital and other physicians. But they are out for themselves. You are out for yourself. Joint and several liability, again, I just mentioned this real quick because you may see this. Hospital-sponsored insurance companies, sometimes hospital will give you a special rate on insurance. And what happens is you have a joint defense with the hospital. There was a case in Michigan where they had joint defense. At the end of the original case, the attorney said, you got to let the hospital out of this. The hospital didn't have anything to do with it. They left the doctor there by himself. $32 million judgment against the doctor by himself. So again, be careful when you have joint insurance. As far as the conduct of a malpractice suit, you have a pre-suit investigation, notice of intent in some states, which means they're going to basically a stick-up letter. If you don't give us money, we're going to sue you. They will then give you a complaint. You'll have interrogatories. They'll ask you a bunch of questions that are sort of difficult. The lawyers are very, very smart. Plaintiff lawyers are smart. Don't ever kid yourself. And they'll have the famous question, do you still beat your spouse? Difficult question to answer. Either way, you're going to be in trouble. And then discovery depositions. In the discovery deposition, they're trying to nail down what your opinion is, and they're trying to evaluate you as a witness. Are you going to get angry? Are you going to get upset? And what you want to do is be very careful. Now, they're going to do Google searches on you. They're going to check your curriculum vitae. They'll look at all past depositions. They'll look at all past legal problems. They'll see if you were divorced. They'll see if you had underage drinking when you were 16. They will do anything and everything. But you got to remember, the advantage that you have as a physician, as a nurse, as a technologist, no matter how much a plaintiff attorney reads, they can never know as much as you know about your subject. Okay. And And these show some of the attorneys. These are my favorite attorney questions. Now, doctor, isn't it true that when a person dies in his sleep, he doesn't know about it until the next morning? Attorney, so the date of conception of the baby was August 8th. Yes. And what were you doing at that time? You were not shot in the fracas? Oh, no. I was shot midway between the fracas and the belly button. Are you qualified to give a urine specimen? Been qualified since early childhood. Doctor, how many autopsies have you performed on dead people? All of my autopsies are performed on dead people. Now, this is one of my favorites. Doctor, before you performed the autopsy, did you check for a pulse? No. Did you check for blood pressure? No. Did you check for breathing? No. So it's possible that the patient was alive when you began the autopsy? No. Well, how can you be so sure, doctor? Well, because his brain was sitting on my desk in a jar. But you see, they don't give up. The plaintiff attorney don't give up. But could the patient still have been alive? Nevertheless, been alive. This was probably one of my all-time favorite answers. It's possible he could have been alive and practicing law somewhere. Okay, if you're going to give a deposition, 1, maintain your composure. 2, answer only direct questions. 3, answer the question that's asked. Don't try to embellish. People think that, never try to educate the plaintiff's attorney. They think, if I explain this to the guy, he'll just drop the lawsuit. He just doesn't understand that I didn't do anything wrong. So I'll just explain all this stuff, and he'll just drop the lawsuit. In a word, never. Okay? Be prepared. Remember, most cross-examinations are suicidal rather than homicidal. Lack of concentration, as in the operating room, as in the cath lab, as in the angio suite, can be fatal. All right, they're going to go to case evaluation, the settlement conference, and trial. These are all things. The last couple things, last question I always ask, can I sue the plaintiff's attorney for filing a frivolous lawsuit? In general, the answer to that is no. If they violate court rules or you can show malicious prosecution, yes, but in general, no. If you settle a case, are you admitting that I committed malpractice? The answer to that is no. And I say this all the time. It's a business decision. Make a smart business decision. Not, well, I'm going to clear my name. It's silly. It's going to cost you money. It's going to cost you time and potential significant liability and money. So make a smart business decision. I'm not telling you to settle every case, but be smart. You don't lose time. There's no risk of personal excess liability, no admission of liability, and no finding of liability. It's obviously best to avoid being sued, but you can't avoid being sued. So what do? You know how to avoid obvious risk. You understand the basic legal concepts of a medical malpractice suit. You know when to hold them, when to go to trial, and when to pursue it, and when to fold it, when to just settle the case. And most important, always, document, document, document. Thank you. Okay. Jeb, I guess on the thing here, you're sort of up next here with the star clause.